Hello, dear friends, colleagues, clinicians. Hope you are doing well in this quarantine. Hope you are staying home to stay safe, and hopefully, we will pass this virus in a short period and we will return to our normal lives. My name is Mahmoud Chaushli. I have a Master of Science in Conservative Dentistry, and I practice mainly microendodontics in my practice. Today, I will be with you with my lecture, Modern Concepts of Root Canal Treatment. All of us in our clinics, we practice endodontics or root canal treatment. As our patients' awareness and education is increasing day after day, so they demand to keep their tooth in the oral in their dental arch as long as possible rather than extracting it. So root canal therapy has a high demand in the recent 10 years because, as I told you, the patients are requiring to do root canal treatments. So all of you know that root canal treatment is mainly somehow is concentrated in three main points: the shaping and cleaning and packing. And may each one of you have a specific technique in his or her clinic and practicing it and seeing it that it should be successful for their patients. Today in my lecture, I will try to discuss some kinds of updated and newest methods and techniques, and for sure they are evidence-based and they have clinical trials and clinical success. Including specific materials which is related to the shaping, specific kind of tools that's related to the cleaning, and some kind of a new technique which is related to packing. All right, so let's go. We will start with the shaping of the canal. All of you, after a proper access cavity opening of our root canal system, we must shape our canals. And as you know, in the 2020, in my opinion, it is considered as a drawback if you are still using hand files for shaping your canals. Because most of the hand files, they are stiff, they are stainless steel, and eventually you will end with very lot of procedural errors, procedural drawbacks, and at the same time, you will have not a predictable prognosis for your patient. In my opinion, hand files should be used only for working length determination, patency, or some kind of freeing. Otherwise, hand files should not be used for shaping of the canals, because eventually also you will lose a lot of time inside the clinic, the chairside time. It needs a lot of chairside time, and also you will have a fatigue for your neck, back, and also your fingers. For example, this case, which I have treated it before maybe 2 months, the patient came to my clinic that's suffering from a severe pain in his maxillary second molar. After proper diagnosis and pre-operative X-ray, I see a very severe curvature, as you can see, in the mesiobuccal canal, the MB1. This curvature is considered a very difficult situation for the clinician. And if you think to shape this curvature with your hand file, it's, in my opinion, somehow impossible, because you will end with some kind of procedural errors, mainly a ledge, or if you work without any cushion, you will end even with an instrument separation, just at the curvature, at the beginning of the curvature. So instead of this, we choose a proper rotary file with a proper alloy, and we could achieve a proper shaping of the curve and packing it with a suitable obturating material in order to have a predictable long-term success. So the main problem and the main question that usually I face it from my students, and also I receive this question a lot from other clinicians, is that what system should I depend on? You have a dozen of systems in the market. You should either choose a ProTaper, or I should choose Micromega, or I should choose any other kind of brand. And each one of them is telling that mine is the best, mine is not it's unbreakable, and do this and that. So Each one of them is making their product is the best. But we should, as I told you, we should depend on the literature and clinical trials, and we should be evidence-based, and we should depend on scientific articles. So if we return to the literature, if we check the alloys and the inventions which have been done by the scientists in the laboratories when they are trying to invent specific alloys and specific rotary files that can achieve the required level of satisfaction by the clinicians, which is, that's to say, a super elasticity, a memory effect, less damage to the dentin, cyclic fatigue, torsional fatigue, all of these that should be controlled by the material. Mainly, they invent three main alloys, and that's to say, three different wires. It is the CM wire. The next one, it's gold heat treated or blue heat treated, and the last, which is the Maxwire. And the most common ones with these wire technologies, they are the high flex EDM by Coltin, and you have the XP Endofinisher and Shaper by FKG. Which these two instruments, in my opinion, I like them, and they are somehow very effective in cleaning the canal and doing a proper shaping for our canal without any, not to say that without, but with minimal procedure errors. That's to say, the clinician should control the procedure errors. So they reduce the risks that you may face during your treatment procedure. And when we discuss that, we will also pass to gold heat treated and blue heat treated rotary files, which is very common in our region, in Kurdistan, and also in our country. That's to say, it's very common between the dentists, and there's a lot of Chinese brands that's fabricating this kind of rotary files. So this is the illustrating diagram for the high flex. As you can see, it has a very good access opener, and it has glide path, and the glide path depends on you which kind of glide path you are going to use. It's up to you. Even if you use a hand file for checking the patency, then the shaping files. The shaping files, it has tip size 20, taperness 0.4, and it has also taperness 0.06, that's to say 6%, also tip size 25. And also it has a tip size 25 with the high flex 1 file. So this is a short video clip I want to share it with you. Very good for you to show. Debris in the forward direction, and it's super elastic. Never seen anybody do the things you do before. Okay, this is one of the cases which I have been treated it with the high flex rotary files, and what has a unique feature is that the high flex requires a very high speed with your rotary files, so it's very effective, and what's important is that it will reduces the chair side time. You will end with a very severe situation like this. With this case, it has very severe curvature and somehow considered a difficult endodontic case. So you will end by treating this case in a very short period because it is somehow very effective. As you can see, this case in the mesiobuccal canal have a very obtuse angle, which if you try to prepare it without somehow a caution or experience, you will end with instrument separation, or you will end with a ledge and a lot of headaches if you're not treated properly. But thanks to God, we do manage to do the shaping properly, and after that packing the canal with the proper obturating material. and have a predictable prognosis for a patient. The next file, it is the Maxwire. Maxwire, it's a wire that's introduced by the FKG. It is, as you can see, it has a specific design. What is important that according to many studies and according to many articles, it says that it cleans the whole surface of the tooth as it touches the entire canal areas, as it touches the entire dentin inside the canal. For example, this is a study that has been done to compare the preparation between the normal standard Nite file and the Maxwire finishers. As you can see, the green area, it is the untouched area, which is considered as the bacterial residue. And on the other side, the vice versa, the whole canal is red, which is indication that the whole canal has been touched with the file and it's very effective in removing the debris. Again, I recorded a short video clip for you to show you the motion and the effect of the XPShaper. As you can see, I'm inserting it inside the canal, and if you check the canal, concentrate on the canal, it touches the whole area. And with the 5th generation feature, which has one stress area and one relief area, so you don't have the risk for the breakage in this file. This is one of the cases that I have been treated with the XPShaper finisher. This is a patient that came to my clinic with severe pain in his upper six. As you can see, a big cavitation, big fracture distortion. The patient was young. That's why I have a very large palatal canal, as you can see. So I have two chances, either to choose a suitable instrument that will clean my canal without reducing the thickness of the dentin and pruning the root for the root fracture, or either I'm going to use larger sizes of files until I achieve the desired cleaning. So I choose the XPShaper finisher, just a simple procedure. It cleaned my canal properly, and at the same time I kept the dentin as much as possible, or that's to say as practical as possible. We will not keep the infected dentin with the bacterial residue. We have to remove all the biofilm, but at the same time we keep the tooth structure around the root as strong as possible, so that we will have a good long prognosis. As our patient is young, so this tooth should serve the patient for a long period of time. Okay, this is another case. Again, as you can see, a very wide canal, a single canal in the preoperative X-ray. So after proper access cavity opening and for sure in the rubber dam, your entire procedure of root canal therapy should be completely under rubber dam. There are no any excuses. This is the working length check and proper cleaning with and proper shaping with the XPShaper finisher. And there was a surprise for me actually at the end of this case, because after proper actuation with the bioceramic sealer, I found a deep split just at the end of this case, which is considered a very rare situation and very difficult to manage, which we were lucky to go and fill these two deep splits. And this is achieved with the high power of activation, which we will discuss it in a bit in this lecture, and with the bioceramic sealer, the high flowability of the bioceramic sealer. Okay, now you may say that these files, okay, they are very good and they're perfect, but at the same time they are somehow costly and they are somehow difficult to achieve in our region maybe, but it's somehow it's available in the market. But usually a lot of clinicians nowadays depend on these files. They are a Chinese brand, but they are somehow suitable for a single-use root canal treatment. They are heat-treated blue or gold rotary Nite files. What they did, they play with the artensitic and martensitic faces of the Nite wire, and they try to build a super elastic rotary file. At the same time, they have a good shape memory. So I will discuss now what you are going to do when you try to do a proper cleaning for your canal. What's the strategy that you have to follow? The taperness that you must achieve in the canal, in my opinion, either 4% or 6% is enough. You don't need to go larger tapernesses. This is according to my opinion, and it is evidence-based. For the tip size, you must have either size 20 tip size or size 25 in most of your cases. But sometimes, for example, a young patient with wide apical foramen or certain situations, you may need to go larger tip sizes to achieve the desired clinical. But in most of our situations and in most of our clinical cases, we end with a tip size 20 or 25. What is important in preparation is that, in crown down preparation, is that you don't need to jump from a single file to a larger file. Most of the clinicians, they think in order to reduce their clinical time, the chairside time, they jump from a certain file to a larger file, which you will have a lot of procedure errors, which is a very big mistake. So we will pass. We have a tooth. We want to do a root canal therapy for this tooth. As you can see, the tooth is infected completely. This is a correct section of the tooth. So we must do first thing the coronal part preparation. Then we must switch to middle part preparation, and then we will do the apical part preparation. You must follow these 3 steps in order to achieve the desired level of cleaning and at the same time without doing any procedural errors. So we will start with the pre-flaring or coronal pre-enlargement. What does, according to Rudel, the pre-enlargement has a lot of advantages. As you can see, it increases tactile sensation, remove debris, 3D cleaning, post-operative pain, improves diagnostics. So the beginning is that the pre-enlargement is very important. You should not just do an excess cavity opening and then after that you will pass to shaping. You must have the pre-enlargement. So coronal preparation, or I usually like to use the term negotiation. You are negotiating with the canals in order to reach to the apex. So you will start with your orifice opener, and it is up to you what kind of orifice opener you are going to use. There are dozens of orifice openers in the market. You can choose one and use it in order to prepare the coronal part. So the coronal part involves that you have to put either sodium hypochlorite or a chelating agent. You have to scout it with a size 10K file and enlarge it with SX or any kind of orifice opener. And what is important is that there's a term which I like it. It is IRI, which is irrigate, recapitulate, irrigate. That's to say, always use a hand file, size 10K file, in order to maintain the patency of the canal, in order to check the patency of the canal during this procedure negotiating. As you can see, this is a short video clip demonstrating the effectiveness of the path files. The path files, they are not standardized. As you saw that it comes with different sizes, size 30 or 50. It is very effective, as you can see, as it reaches into the apex and passes through the apex, and sometimes very effective in removing the necrotic pulp from the canals. So after the coronal pre-flaring, you will switch to path files. After achieving the path file, you have to check your working length. Now you are ready to check your working length with your apex locator, and if you want to be 100% sure, you can take a object localized X-ray, a slope technique. Then after that, you will start doing the middle part preparation. For the middle part preparation, we will do what? We need a sodium hypochlorite. Then after that, we will enlarge the canal with the sequence rotary files. Do not jump, as I told you. What's the technique required? It is the brush out technique, like a painter, as it paints. So you have to brush the canals slowly and gently. Then IRI, irrigate, recapitulate, and irrigate again. So you reach the apical part now. So what is required is that, again, sodium hypochlorite, insert the rotary file to the full working length, confirm the canal patency with size 10, brush out technique again, then irrigate, recapitulate, irrigate, IRI. This is very important. By this, you will have a predictable preparation, and mostly, as I told you, for narrow, small canals, you will have 4%, tip size 20. For large canals, that's to say wide canals, you will have taperness 6 and tip size 25 or 30 maximum. This is according to my experience. Some may disagree with this and you may say to jump to larger sizes, but in my opinion and according to a lot of literature which I have reviewed, it's enough. So this is a case which I treated it and I wanted to show to you. As you can see, this kind of situations, this is called a fishhook apical end. This end of the distal canal, it is very dangerous part of the tooth to treat. As you can see, any kind of rotary file may reach here and engage this curvature and separate here. And when it is separated, it's a big trouble for you. It's a headache. You cannot just bypass it easily, or I don't know, you may even think of different other procedures. But in order to do a very smooth root canal therapy for this situation, you must follow the technique which I have discussed before in order to reach the desired level of proper root canal therapy and a predictable prognosis for the patient. Also, in situations when you have a very fine blocked canals, again, you must use a proper technique and a proper cleaning method. As you can see in this case, it's somehow, the mesial canals, it's not visible even in the X-ray. It's somehow in the apical part, we see some lines, but here there is nothing. The distal part is disappearing in the apical end. So we could manage to open these canals with the chelator and hand files. Then we achieved a proper obturation. Then the patient was referred to the prosthodontist to put the crown on it. Okay, now I finished the first part of my lecture. We will switch to the cleaning. Cleaning is very important in root canal therapy. The shaping that I discussed before is considered as one of the main parts for a successful root canal therapy, but at the same time, if you want to achieve the desired level of success in your clinic, you must have very high irrigation. If your treatment is 45 minutes for, I'm not talking about a single tooth, if your treatment is 45 minutes for a multiple tooth like this, you may spend 15 minutes on shaping and 30 minutes on irrigation. Irrigating materials, including sodium hypochlorite, chelators, EDTA, saline, chlorhexidine, different kind of irrigating solutions. Each one of them must have a specific protocol to follow in order to achieve the desired level of success. For example, for sodium hypochlorite, you need heating using your system B. You need activation with sonication power in order to achieve the desired level of cleaning inside the canal, and after that, achieving a successful root canal therapy. So, my protocol inside the clinic, inside the tooth, and this protocol, it's not what I did it by myself or I found by myself. It's completely evidence-based and it is suggested by the scientists. So, what's the protocol? The protocol involves that you must have a sodium hypochlorite 5.2%. Some clinicians like to use sodium hypochlorite that has been diluted. For example, 2.5, 3%, but in my opinion, 5.2. The time of the sodium hypochlorite inside the canal should be 20 minutes. It's not about shaping the canal and after that irrigating the canal with some syringe of sodium hypochlorite and you say, and voila, I did a very good cleaning of the root canal. This sodium hypochlorite must remain inside the canal for a period of time, which is 20 minutes. And it's not about like you will put sodium hypochlorite inside the canal and you go outside, you will respond to your emails, you will chat in your messenger, and you will come back to continue your treatment. This is not logical. You must do specific kind of activating or renewing your sodium hypochlorite inside the canal, heat inside the canal with the system B, and a lot of flush in order to achieve the desired level of cleanness and in order to open the lateral canals, which is impossible to be opened without proper activating of the sodium hypochlorite and the chelating agent. So you will put the sodium hypochlorite inside the canal, activate with sonication with 20 seconds. Then you will change the sodium hypochlorite. You will do it again and again and again and again until you will finish this cycle. Then after that, you will use a saline flush between two materials. You must have a saline flush. Then you will use EDTA, chelation, 70%, in order to remove this mid layer, which you did it by yourself during the shaping of the canal with your rotary files. And the saline EDTA should remain inside the canal for 1 minute and activation for 20 seconds. Then after that, you will do flushing of your root canal system with the saline, and that's it. You have a good cleanness of the canal. According to my opinion, the best thing for activation, which I use it in my clinic, it's eddy. Eddy is produced by BDW. It produces acoustic streaming inside the canal, which produces heavy high pressures inside the canal and produces heavy bubbles of the sodium hypochlorite, which will allow to reach into the deepest part of the lateral canals and clean it and open it so that it will be then obturated with the bioceramic sealer. As you can see, the eddy, it is very effective and it's very fast, but you should be careful with using it. It is comes with specific tips, and it is attached to the your air scaler. The technique is that you must insert your eddy inside the canal about 3 to 5 millimeters short from your working length. Then after that, you do the activation. And when you do the activation, between the steps, you will see the bubbles of the sodium hypochlorite is shown on the orifice of the canals. As you can see, this is the with high magnification. These are the mesial canals, and this is the distal canal. As you can see, the sodium hypochlorite is going, bubbles is going everywhere. So by this, you will achieve a high level of cleaning of the canal, and also even in situations when you need to do the cleaning of the isthmus area. For example, in the premolars, upper premolars, the isthmus area is considered as a challenge for cleaning. These areas are cleaned only by activating of the sodium hypochlorite inside the canal. This is a short video clip which I recorded in order to show to you the effect of the eddy inside the canal. As you can see, it is very effective and it produces the required amount of shock of the sodium hypochlorite inside the canal to clean the whole area. Now, the third part and the last part of my lecture, it's packing of the canal. Packing of the canal after proper shaping and proper cleaning of the canal. Now we are ready to do the packing of the canal. The most common and the most famous and the most popular technique, which we use it every day in our clinics, is the in order to achieve a desired 3D obturating of the canal, it is the continuous wave obturation, which you are going to put your trial cone, the Guttapercha cone. After checking it, it's properly fit, and you have a good tuck back. You will apply your system B in order to heat it about 5 or 3 millimeters short, and you will leave the Guttapercha, the apex. Then after that, you will pack the canal with 3 millimeters of Guttapercha. You will use your pluggers to plug your Guttapercha. And after that, again, 3 millimeters of thermoplasticized Guttapercha, and you will plug more. Eventually, you will achieve a 3D obturation, which is known as continuous wave obturation. But, and this is some of my cases which have been treated with this technique. As you can see, this was a completely blocked canals. After proper shaping and cleaning, we could achieve proper obturation and 3D completely sealed with a beautiful sealer path in the mesial canals. This is another case which, after removing of the post screws, we have lots of defects inside the canal which have been done previously, like you have a defect here due to the improper placement of the screw, a defect here, here, and all of these are controlled with the proper packing of the curvature, as you can see in the post-operative image. But nowadays, there's a new technique which I consider it is the future, which is called synchronized hydraulic condensation obturation technique. It is achieved by what? Or it is called a single cone technique with using the bioceramic sealer. There's an invention of lots of bioceramic sealers, but one of them which I like the most, it is the Silacel. Silacel is the sealer which I have been using it recently. It is very effective. It is have a lot of features in it, including an antibacterial feature, optimal biocompatibility, excellent sealing ability, and it is the most important thing which is unique in it. It has a very high flow. It flows everywhere. You will put just a small amount inside the canal, which I will show it in a bit in a video clip. It just flows everywhere. So lateral canals, I don't know, isthmus area, anything, any irregularities, everything, it is obturated with this material. It's like a magic. So, sorry, as you can see, it's a three-step obturation. It's remarkably simple. I did this diagram for you just to know what's going on. You will just inject the bioceramic sealer inside the canal. It flows everywhere. And after that, you will insert the cone, cut it, that's it. Some of the scientists and some of the clinicians till today, they may not recommend this technique, but in my opinion, this is the future. We don't know after 10 years or 15 years, we don't know what's going on, and we may also stop using curvature and fill the canal with a bioceramic sealer or something substitutes it. So what's going on, we will see it hopefully, and day after day, new technique, new material. So this is the newest technique for obturation, and that's why I wanted to show it to you. And I'm going to show you some of my cases which I treated it with this single cone technique with the bioceramic sealer. As you can see, this is the case. I took the working length, a normal case, and I put my trial cones, as you can see, normal, and after that, this is the application of the Cerasil, as you can see. What's important is that check the lateral canal just at the apical part. Check this lateral canal, as you can see. It's like magic. You cannot obturate this canal with anything. It's somehow very difficult to reach this area. As you can see, the Cerasil is just past here, and there is a sealer path here. So it's considered a very effective material. And you may say that there is an extrusion here in the mesial canals, but it is 100% biocompatible. It's a very hard material. So I will share the follow-up of this case I have the 9-month follow-up, but I'm waiting to do a 14-month follow-up, and after that I'm going to share it that the lesion around the mesial canal is going to be lost, and at the same time the bioceramic sealer is in its place without any problem. So it's very effective in my opinion. This is another case which I told you. It's the premolars. As you can see, this is a dead tooth and this is a failed root canal therapy. After proper shaping and cleaning and proper activation of the sodium hypochlorite, for sure, we put the trial cones, we took the x-ray, and this is the after obturation. If you check the isthmus areas, the irregularities, everything is controlled with the bioceramic sealer. Thank you guys for listening my lecture. Hope you enjoyed it. Hope you get the most benefit of it. Hope we will discuss more scientific lectures and scientific events with the company Advanced Dent, which will provide this opportunity for us to share this lecture here. If you want to reach me, you have my Facebook, Mahmoud Chaushli, and you have my phone number. It has WhatsApp, Viber, Telegram, anything. Anytime you want to contact me for a question, or if you want to share a case with me, I'm ready. So hope to see you guys in very well situations, and hope we will pass this bad period of having this bad virus. Stay home, stay safe, and hopefully we will return to our normal life. Thank you very much. Bye-bye.